Welcome back to the Deep Dive, where we take your stack of information and turn it into actionable, synthesized knowledge.
Hello.
Today, we are cracking open a genuinely fascinating puzzle. It sits right at the intersection of immunology, muscle control, and even skin health.
That's a big one.
We're diving into the world of dermatomyositis and polymyositis. You'll see them called DM and PM.
And these are a group of conditions that are, well, they're rare, they're immune-mediated, and frankly, they can be deeply confusing, even for clinicians.
Right. And the sources you provided, they map out not just the broad clinical picture.
No, not at all. They get into the subtle, almost microscopic details that now define them. The big puzzle here isn't just that the body attacks its own muscle tissue.
Which is already a huge deal.
It is. But the real story is how it executes that attack. And realizing that what we used to casually call polymyositis has, well, it's been fractured into several much more precise diseases.
And that's really the core mission for us today, isn't it? Guiding you through the stack to keep track of those vital distinctions.
Yes.
So at their core, these are inflammatory myopathies. They're characterized by muscle weakness and inflammation, usually in the proximal muscles.
Right, the muscles closest to the trunk of your body.
But the moment you add that distinct cutaneous component, the skin findings,
Yeah.
you're moving squarely into dermatomyositis, or DM.
Exactly. And the most important insight from all the modern classification, really the central theme, is this fundamental realization. The broad, old-school definition of polymyositis, or PM, is shifting dramatically.
How so?
Historically, PM was a catch-all bin. It was for any inflammatory muscle disease that just lacked the DM skin rash.
A diagnosis of exclusion, basically.
Pretty much. But now, with the technology to identify highly specific syndromes, things like antisynthetase syndrome or immune-mediated necrotizing myopathy, and even inclusion body myositis, the pure diagnosis of PM is becoming smaller and smaller, almost residual.
And these new categories, they're not just new names, are they?
Oh, not at all. They reflect completely distinct pathophysiologic pathways, and that means they require radically different approaches to treatment, and, they have very different outcomes.
So we're essentially witnessing the deconstruction of a medical definition in real time. We're going to walk you through that whole landscape, and we'll start with some of the baseline data. So before we get into the symptoms themselves, I want to talk about the numbers. I mean, how rare are we really talking about here?
It's a good question. When we discuss the inflammatory myopathies, we are definitely moving into the domain of uncommon disorders.
Which has to make diagnosis a challenge from the get-go.
It absolutely does. If you look at the population-based studies, the annual incidence for all the subtypes of dermatomyositis is somewhere around 1.1 per 100,000 person years.
Okay, can you put that into context for us?
Sure. So the prevalence, which is how many people are actually living with it at any given time, is around 13 per 100,000. So if you're in a city of, say, 1 million people, you might expect to find around 130 people living with DM.
So it's a low number, but it's certainly not vanishingly rare. You'd encounter it in a large clinical practice.
You would, eventually.
And are there specific demographics? I mean, who is most affected by these conditions?
Absolutely. There are some really strong demographic trends that, they offer clues as to what might be going on underneath.
Like what?
Well, first, we see a really strong increase in incidence that's linked to age. For instance, for patients who are 80 and older, the incidence jumps pretty significantly, up to 3.2 per 100,000 person years.
So it's increasingly a disease of older adults.
It is. Second, both DM and PM show a notable female-to-male predominance. This is a very common finding across many autoimmune diseases.
That makes sense.
And finally, polymyositis itself, it tends to affect mostly adults and is extremely rare in children. In kids, the inflammatory myopathy equivalent is usually something called juvenile dermatomyositis, or JDM.
That strong connection to age and the female predominance. It really hints at a complex interplay of genetics, environment, maybe even hormone status.
For sure.
But this brings us to the elephant in the room that we touched on a second ago. Polymyositis, or maybe the declassification of it. Why is that term falling out of favor? Why is PM almost a residual diagnosis now?
Because the initial classification was driven by, symptoms and exclusion, not by mechanism. the sources are very clear on this historical context.
Right.
In the past, if a patient showed up with muscle weakness and inflammation, but, and this is the crucial part, they didn't have the classic DM skin rash, they were just labeled PM.
It was a default
It was
diagnosis.
a default. But with modern tech-specific serology for autoantibodies, highly sensitive muscle enzyme tests, and really detailed histologic analysis of muscle biopsies, we realized something huge.
What was that?
That this umbrella term, PM, it actually contains several fundamentally different diseases that were just masquerading under one clinical presentation.
It sounds like PM was less of a diagnosis and more of a temporary holding cell for patients until science could give them a better, more accurate label.
That is a perfect way to put it. It was a clinical bucket that we now realize needs to be emptied and sorted into these specialized, mechanism-driven diagnoses.
And that shift is crucial. Why?
Because if you don't know the mechanism, you can't optimize the treatment. You're just throwing broad immunosuppressants at it and hoping for the best.
Okay, so let's get specific. Let's detail these conditions that were previously just lumped into PM.
Yeah.
What are the new specialized diagnoses that have taken its place?
There are 4 main groups that have been split off, and each one has really distinct features.
Go on.
First, and probably one of the largest groups, is antisynthetase syndrome. You'll see it abbreviated ASYS.
Okay.
Now, these patients might look a lot like PM. They have the muscle weakness, they don't have the classic DM rash, but they have their own very specific set of autoantibodies. The famous one is anti-Jo1.
And what does that syndrome look like clinically?
Their clinical fingerprint includes not just the myositis, but also significant interstitial lung disease, ILD plus arthritis, and this phenomenon called mechanic's hands.
So ACS is really a systemic connective tissue disease, not just a muscle disease, and is all defined by that autoantibody signature.
Precisely. The antibody tells you what to look for. Second, we have immune-mediated necrotizing myopathy, or IMNM.
That sounds serious.
It is. This is a very severe form. Clinically, it looks like an acute, severe PM, just massive weakness. But when you look at the muscle biopsy, histologically, it's completely distinct.
How so?
It involves massive muscle necrosis, often driven by specific antibodies like anti-HMGCR or anti-SRP.
The anti-HMGCR one, isn't that the one linked to statins?
Yes, that's the one. It's frequently seen following exposure to statin drugs, which means it's a form of drug-induced autoimmunity.
That's fascinating. A direct link between a really common cholesterol medication and a specific severe autoimmune mechanism.
It really highlights the power of the autoantibody to define not just the disease, but in some cases, a potential trigger.
Okay, so that's 2. What's the third?
The third is what we used to call overlap myositis. This is where the muscle inflammation occurs alongside other known connective tissue diseases that have their own established criteria, like systemic lupus erythematosus, SLE, or systemic sclerosis, SSC.
And the fourth, which I know causes major diagnostic headaches and a lot of confusion, is inclusion body myositis, or IBM.
Right.
Why is IBM so frequently mistaken for PM, and why is that distinction so incredibly important?
IBM is the most commonly misdiagnosed inflammatory myopathy, period.
Yeah.
Many patients who are initially labeled with chronic or refractory PM eventually turn out to have IBM.
And the distinction is vital because
IBM is typically refractory. It does not respond to the standard immunosuppressive treatments we use for DM and PM.
So you could be treating a patient for years with powerful drugs.
And not only are they not working, but you're exposing the patient to all the side effects. Bone density loss, infection risk for absolutely no benefit. It's a critical error to miss.
So how do we spot IBM when it's masquerading as PM? What are the tells?
The clinical presentation starts to diverge over time. For one, IBM has a much more insidious onset. It develops slowly over years.
Whereas PM is faster.
Right, PM is typically subacute, developing over weeks to months, but the distribution of the weakness is the real key.
Okay.
IBM is characterized by asymmetric weakness. It's not the same on both sides, and it often involves distal muscles first.
Distal meaning farther from the center.
Exactly. The wrist and the deep finger flexors are classic targets. PM, on the other hand, is classically symmetric and overwhelmingly proximal.
So the old criteria for PM didn't require a biopsy.
Not always for a probable PM diagnosis, but that's all changed. The sources emphasize that all suspected cases now really need a muscle biopsy to definitively rule out IBM or IMNM. It's not optional anymore.
This reclassification really drives home the shift in medicine, moving away from just describing symptoms, polymyositis, weak and sore muscle, and toward defining the actual molecular mechanism.
That's the goal. Precision phenotyping. It's everything.
Now, let's look at the other side of the spectrum. Let's talk about dermatomyositis, but specifically clinically amyopathic DM, or key ADM.
Right.
This is where the patient has the classic DM skin findings,
Right.
but no clinically significant muscle weakness. To a layperson, that sounds totally contradictory.
It is contradictory, which is why it was historically and somewhat clumsily called dermatomyositis, myositis.
DM without the myositis?
Right, DM without the muscle inflammation. The incidence is estimated to be about 0.5 per 100,000 person years, and it accounts for a pretty significant portion, somewhere between 10 to 30% of all DM cases.
So these key ADM patients, they have the textbook rashes, but they feel entirely normal in terms of strength, and their blood work for muscle enzymes is normal.
That's right. They might have a terrible rash, but be able to go to the gym and feel perfectly strong.
So what's the critical clinical implication of diagnosing key ADM? If they feel strong and their enzymes are normal, why should a clinician worry beyond just treating the skin rash?
You worry. You worry deeply. Because of the risk of systemic involvement that proceeds without the muscle disease acting as a warning signal.
So the skin is the only warning you get.
It is. Despite the lack of muscle involvement, KDM patients still require a thorough and, frankly, urgent evaluation for major systemic diseases. Specifically, they have a very real, life-threatening risk of developing rapidly progressive interstitial lung disease,
Right.
or ILD.
The lung scarring we mentioned.
Exactly. Or having an underlying undiagnosed malignancy. The muscle is spared, but the immune attack is still firing on other vital, non-muscular organs.
So that's the crucial point. Normal strength and normal enzymes do not mean the disease is benign. It's not just a cosmetic issue.
Not by a long shot, it can be a ticking time bomb.
Okay, let's move on to the actual physical experience of these conditions. For the classic forms of DM and the remaining true PM cases, the cardinal feature is muscle weakness.
Yes, muscle weakness is the absolute common denominator. It's present in over 90% of PM patients, and about 50 to 60% of DM patients will present with it initially.
And the key to diagnosis is understanding the pattern of this weakness, right?
It is. The pattern is consistently symmetric and proximal.
Okay, let's slow down here and use some concrete, real-world examples. Let's make this proximal weakness tangible for you. What does it actually look like when someone has trouble with the muscles closest to the center of their body?
Think about the biggest, most functional muscle groups, the shoulders and the hips. The patient won't usually notice weakness in their hands or feet at first.
Okay.
Instead, they'll notice an insidious or subacute development over several weeks to months. It rarely hits acutely like a lightning bolt.
And the daily examples.
The classic ones are increasing difficulty climbing stairs or struggling to rise from a low chair or the toilet without having to use their hands to push off.
Right, using your arms to help your legs.
Exactly. Or even simple acts like reaching overhead to put something on a high shelf, carrying heavy groceries, or lifting a gallon of milk.
Things we all take for granted.
Completely. These activities rely heavily on the deltoids, the hip flexors, abductors, and extensors. Those are the big power muscles.
So the muscles that generate power for the core movements of life are the primary target.
That's a perfect way to describe it. We're talking about the deltoids in the shoulders and the muscles around the hips. Another classic functional issue is weakness of the neck flexors.
Neck flexors.
Yeah, difficulty lifting your head off a pillow. It's sometimes called the dropped head sign. And this happens with relative sparing of the neck extensors, the muscles that hold your head up.
And if you see significant isolated distal muscle weakness in the hands or feet, your alarm bells should be ringing for something else.
Immediately. Your index of suspicion should immediately shift toward IBM, which we just discussed, or maybe a muscular dystrophy or peripheral neuropathy. The pattern is everything.
What about pain? Is this a very painful condition?
It can be. Myalgias, which is just muscle pain or tenderness, do occur, but they're generally present in only about 25 to 50% of cases.
So, half at most.
Right. And they are typically mild to moderate. Severe crippling muscle pain is far less common in DM and PM than in some other conditions, like a viral myositis or the rare myopathies defined by massive necrosis.
So the primary complaint is usually the weakness and the fatigue, not so much intense pain.
That's right. It's a failure of function more than an overwhelming pain signal.
Okay, now we get to the defining characteristic of dermatomyositis, the skin findings. The sources describe this as a kind of internal artwork, often showing up before the muscle weakness even starts.
That's what makes DM a visual diagnosis in so many cases. The skin findings can precede, accompany, or follow the muscle weakness, but they are highly, highly specific, We have several distinct cutaneous features that are so characteristic they're considered pathognomonic.
Pathognomonic meaning if you see it, you've basically made the diagnosis.
It means they're almost diagnostic of DM on their own, yes.
Let's start with the two big ones, the Gottron papules and the heliotrope eruption. Can you describe the Gottron papules in detail for us?
Gottron papules are key. They are sharply defined, erythematous, which means red to violaceous, which is a red-purple color.
Violaceous like violets.
Exactly. They're papules, so they're small raised bumps, and they occur symmetrically and specifically over the bony prominences of the hands.
Specifically the hands.
The classic sites are the extensor or the dorsal aspects of the metacarpophalangeal joints, the MCPs.
Or knuckles.
Your main knuckles, and the interphalangeal joints, the IP joints, so the knuckles on your fingers.
And there's a distinction in the sources between Gottron papules and the Gottron sign. What's the difference?
It's a matter of location and morphology. The papules are those small raised lesions directly over the small joints of the hand.
Got it.
The Gottron sign is defined as similar erythematous or violaceous macules, which are flat patches or just patches found on the extensor surfaces of other large joints.
So elbows, knees.
Exactly. Elbows, knees, even the ankles. So the papules are specific to the hand joints, and the sign covers the extensor surfaces of the larger joints. They can sometimes have some associated scale, which might lead to confusion with psoriasis.
I was going to ask about that.
But the location directly over the bony joints is the critical distinguishing feature. Psoriasis tends to be more on the fleshy parts between the joints.
Okay, and the heliotrope eruption. The name sounds like it belongs to a flower.
It does, and the color matches that reddish-purple violaceous hue. The heliotrope eruption is a reddish-purple patch found on the periorbital skin,
Or around the eyes.
usually involving the upper eyelids, and it's often accompanied by quite noticeable edema or swelling. When you see that distinct color, especially with the swelling around the eyes, it is highly specific for DM, even though it's not present in every single case.
So beyond those two pathognomonic markers, what are the other classic diagnostic clues that help distinguish DM from, say, lupus or psoriasis?
A major category of clues relates to photosensitivity and where the rash shows up. We often see distinct facial erythema.
Redness on the face.
Patients may present with midfacial redness that looks a lot like the classic Miller or butterfly rash of lupus. However, and this is a subtle but immensely vital diagnostic clue,
Go on.
DM midfacial erythema characteristically involves the nasolabial folds.
Those are the lines running from the nose to the corners of the mouth.
Right, the smile lines. Classic lupus erythema typically spares those folds. That small, easily missed detail carries enormous weight in clinical distinction.
That's a perfect example of how a tiny observation can guide a huge diagnosis. What about the rashes that cover the body?
These manifest as photodistributed poikiloderma.
That's a mouthful. Break that down for us.
Poikiloderma is a complex skin change. It's a mixture of hyperpigmentation, darkening of the skin hypopigmentation, which is lightening, visible telangiectasias, which are like spider veins, and epidermal atrophy, or skin thinning.
So a mottled, changed appearance.
A very mottled, sun-damaged appearance. And in DM, this often appears in sun-exposed areas. We use two very specific descriptive names that define the pattern.
The shawl sign and the V sign.
Exactly. The shawl sign is poikiloderma, distributed across the upper back, the neck, and the shoulders, mimicking where a shawl would sit. And the V sign is poikiloderma in the V shape of the interior neck and upper chest.
We also need to talk about the sensory experience of this rash. Is it typically bothersome to the patient?
Yes, and this is another critical differentiator. The cutaneous eruption of DM is frequently associated with significant pruritus.
Intense itchiness.
Intense itchiness, and this is generally very helpful in distinguishing it from the photo-exacerbated rashes of lupus, which are often not itchy. If a patient with a sun-exposed rash reports severe pruritus, your brain should be strongly steered toward DM.
And then there's the holster sign, which I find particularly surprising because it occurs in a spot you wouldn't typically associate with sun damage.
The holster sign is fascinating. It's poikiloderma found on the lateral aspects of the thighs, precisely where an old-fashioned gun holster might sit.
But it's usually covered by clothing.
Exactly. It's surprising because the lateral thighs are classically considered photoprotected sites. The presence of DM poikiloderma in these unusual, sometimes covered areas strongly suggests that the underlying inflammatory process is driving the skin changes, not just UV exposure.
So it's not just a sun allergy.
It's much deeper than that. This finding, combined with the pruritus and the facial erythema pattern, forms a powerful clinical constellation for DM.
Let's talk about the final, small details on the hands that can indicate active disease. The nail fold abnormalities.
These are microsigns of an active vasculopathy, a disease of the blood vessels.
What are we looking for?
When you examine the nail folds, either directly or with magnification, you're looking for nail fold abnormalities. This includes periungual erythema redness around the nail and abnormal capillary loops.
What does that mean, abnormal capillary loops?
It means you see alternating areas of capillary dilatation or widening and dropout, which is a loss of vessels. You also frequently see cuticular hypertrophy, which clinicians often call ragged cuticles.
So the skin around the nail looks beat up.
It looks beat up because the small vessels that feed it are being attacked. These tiny changes reflect ongoing cutaneous disease activity driven by inflammation targeting those small vessels, confirming the systemic nature of the vasculopathy.
Finally, we should quickly mention the scalp involvement.
Right. Scalp involvement can present with psoriasiform changes and prominent scaling. It can be easily misdiagnosed as severe dandruff or seborrheic dermatitis.
But it's different.
It is. In DM, these changes are often accompanied by severe burning and intense pruritus. And crucially, if you biopsy the DM scalp, it shows the characteristic vacuolar interface changes you see in other DM rashes, differentiating it from the pathology of psoriasis.
So those skin findings are the signature of DM. But even when the weakness is clinically absent like in KDM, the patient is still at risk for major internal damage. Let's shift our focus to the major extramuscular organ involvement.
This is where the seriousness of the disease really becomes evident. Interstitial lung disease, or ILD, occurs in a large subset of cases, roughly 30 to 40% of DM and PM cases.
And ILD is inflammation and scarring in the lung tissue.
It is. And when it occurs, it's often associated with specific autoantibodies, particularly the anti-Jo1, which defines the antisynthetase syndrome we discussed earlier.
But there's one specific ILD association that has to be flagged immediately because of its profound danger.
That's the rapidly progressive ILD. This carries an extremely high mortality risk and is most commonly associated with the anti-MDA5 autoantibody.
That one marker.
That single marker is a massive red flag. A patient with anti-MDA5 can develop severe, sometimes fatal, lung fibrosis and respiratory failure in a matter of weeks to months.
Even if their muscles are fine.
Even if their muscle enzymes and strength are entirely normal, it completely changes the clinical urgency of the situation.
Beyond the lungs, what about the critical process of eating and swallowing?
We frequently see esophageal dysfunction. Dysphagia, which is difficulty swallowing, is the most commonly reported GI symptom.
And what causes that?
This is directly caused by weakness in the striated muscle that forms the upper one-third of the esophagus and the oropharyngeal muscles used for the initial phase of swallowing.
And the consequences are serious.
The functional consequence is severe. It dramatically increases the risk of aspiration, which can lead to recurrent bacterial pneumonia. For older or weaker patients, this aspiration risk is a major source of morbidity and mortality.
And the sources noted significant cardiac risks that often fly under the radar.
Unfortunately, yes. Cardiac involvement is common and often subclinical. This includes histologic myocarditis, inflammation of the heart muscle, and frequent conduction abnormalities you can see on an ECG.
So not always obvious symptoms.
Right. While symptomatic congestive heart failure is less common, the overarching finding is the significantly elevated long-term cardiovascular risk. Patients with DM and PM have a hugely increased risk. We're talking 3 to 4-fold of a myocardial infarction, an MI, compared to the general population.
Even after you control for other risk factors.
Even when you control for other typical risk factors like hypertension or diabetes, this means cardiovascular health and risk stratification must be aggressively monitored in these patients from day one. It's part of the disease.
Okay, here's where it gets really interesting. We're moving from what we see clinically to what we know about the molecular mechanism. This is where DM and the other myopathies split dramatically and provide the strongest argument for that new classification system.
This is the science behind it all.
Let's start with dermatomyositis and the type 1 interferon pathway.
The modern genomics-driven understanding is that DM pathology results from the induction of the type 1 interferon, or IFN, pathway.
The interferons are usually associated with fighting viruses, right?
Exactly. Think of it as a constant, overwhelming viral alarm signal, even when no virus is present. This pathway is what drives the capillary, the myofiber, and the keratinocyte injury that we see clinically in DM.
So what's the proof? How strong is the evidence that the type 1 IFN system is the culprit here?
The evidence is overwhelming, and it comes from large-scale transcriptomics.
RNA sequencing.
Right. RNA sequencing profiling shows that type 1 IFN-inducible transcripts are the single most upregulated pathway in DM muscle and skin. And we're talking about a phenomenal level of upregulation.
Like how much?
For instance, the transcript for IFN-stimulated gene 15, or ISG15, was found to be 570-fold higher in DM muscle compared to normal muscle.
570 times higher.
And myxovirus resistance protein A, MXA, was 280-fold higher. If normal muscle is whispering a molecular message, the DM muscle is screaming this specific viral alarm message hundreds of times louder.
And that degree of upregulation is unique to DM among the inflammatory myopathies.
It is entirely unique to DM. You do not see this in PM, IBM, or IMNM.
So MXA, that resistance protein, becomes the microscopic physical evidence of that scream.
Absolutely. The protein MXA is densely expressed in the muscle fibers located at the edges of the muscle bundles. That's the perivascular region.
Ursicular on the periphery of the fascicle.
Exactly. And because of this high specificity and sensitivity, demonstrating MXA expression in perivascular myofibers has become the most specific histologic marker we have for dermatomyositis. If you see that MXA lit up on a biopsy, you have your diagnosis.
And can we narrow down which specific type 1 IFN is driving this massive signal?
We can, remarkably well. The biomarker evidence points very strongly toward IFN beta, or IFNB, being the primary driving cytokine in this.
Okay.
Transcript profiling shows a specific elevation of IFNB messenger RNA in DM compared to all other myositis subtypes. And this persistent IFNB exposure leads to a sustained accumulation of these antiviral transcripts and proteins, which ultimately causes the signature injury to the vessels and the muscle cells.
That sets up the perfect comparison. We know DM is driven by an IFN beta alarm that causes a vasculopathic attack on the muscle bundle edges. Now let's use histology to compare that to PM and IMNM. How do the key microscopic features separate the three?
The histologic distinctions are the foundation of the new classification. They represent fundamentally different disease processes.
Let's start with the DM pathology under the microscope again, but focus on the location.
Okay. In DM, the pathology is focused on the small vessels in that perivascular region, the muscle fibers right at the perimeter of the muscle bundles. This is where you see the atrophy, the damage.
And the inflammatory cells, where are they?
The inflammatory cells, which are primarily CD4 positive T cells and macrophages, are located predominantly in the perimysial region.
Perimysial meaning around the muscle bundles.
Correct. And crucially, the sources detail that primary vascular injury is seen early. You can identify it by the deposition of the permeable complement component C5b9, also known as the membrane attack complex, in the vessel walls.
And that's evidence of a primary vasculopathy. Yeah, the blood vessels are being attacked first.
Exactly.
So DM is an outside-in attack. It damages the blood supply and the periphery of the muscle bundle, driven by complement and T cells, all kicked off by that IFN alarm.
A great summary.
Now, what about classic polymyositis?
In PM, the pattern is entirely different. It suggests a direct cellular assault. There is no primary evidence of vasculopathy or immune complex deposition.
So where's the inflammation?
Instead, the inflammation is predominantly endomysial.
Endo, meaning within the muscle fascicles.
Right. The damage is mediated directly by large numbers of CD8 positive cytotoxic T cells. These are killer T cells, and they surround and actively invade individual non-necrotic muscle fibers.
So the muscle cell itself is the target.
It's the target, attacked directly by immune killer cells.
It's a direct military invasion, not an infrastructural attack like in DM. Now, how does IMM, immune-mediated necrotizing myopathy, fit in as the third distinct pattern?
IMNM is defined by its damage, not by its cellular infiltrate. It shows widespread, scattered necrotic and regenerating fibers with a relative absence of lymphocyte infiltration.
So you don't see the army of T cells?
You don't see the dense CD4 plus perimeshal cuffing of DM or the CD8 plus invasion of PM. What defines IMNM microscopically is the presence of that membrane attack complex, C5b9, and major histocompatibility complex, class 1, MHC1, expression on the sarcolemma.
The cell membrane of the muscle fiber.
Of non-necrotic fibers.
So IMNM is the result of a powerful complement-mediated attack on the muscle fiber membrane itself. It results in necrosis, but without a large supporting army of T cells surrounding the destruction.
Exactly. The The lack of significant lymphocytic infiltration suggests an autoantibody and complement-driven mechanism of destruction. It's almost like a chemical bomb going off on the cell membrane rather than a prolonged T-cell invasion. And this pattern is characteristic of cases associated with those anti-HMGCR or anti-SRP antibodies.
This molecular fingerprinting brings us to the immense importance of autoantibodies. They are not random passengers. They are highly specific guides to the disease mechanism and, critically, to the prognosis.
They are the molecular keys that define the specific subtype. These autoantibodies are usually mutually exclusive with each other, meaning a patient typically only expresses one major set. And understanding which one you have provides immense prognostic and therapeutic value.
Let's review the high-risk associations defined in the source material. Which antibodies should trigger the most urgent clinical action?
First and foremost, anti-MDA5. We discussed this briefly in the context of Chionidae. This is a massive flag for pulmonary mortality.
Right.
While patients with anti-MDA5 typically have a lower incidence of clinical myositis, they are at a very high risk for that rapidly progressive interstitial lung disease.
And clinically, they look different too.
They do. They often present with distinctive mucocutaneous findings like cutaneous ulceration, digital necrosis, and severe mechanics hands. The takeaway is low muscle symptoms, high mortality risk from the lungs.
So this antibody essentially overrides the clinical picture of strength and just screams about the internal state of the lungs.
It forces the clinician to screen aggressively for ILD, even if the patient appears strong.
Okay, what's next?
Second, anti-TIF1 gamma and anti-NXP2. These are the malignancy markers.
The cancer markers.
They're strongly associated with an increased risk of an underlying malignancy in dermatomyositis. Finding these antibodies immediately mandates a comprehensive, aggressive, and sometimes unusual cancer screening. We can't rely just on the age-appropriate guidelines.
And the antibodies that define that severe necrotizing form, IMNM.
That's anti-HMGCR and anti-SRP. Anti-HMGCR often defines the form of IMNM that follows statin exposure.
Right.
Anti-SRP often presents as a severe, highly refractory phenotype, sometimes in younger patients. But both define that necrotizing myopathy subtype we discussed microscopically, which demands prompt and often aggressive immunosuppression.
And finally, the antisynthetase group, like anti-Jo1.
Right. The antisynthetase antibodies, such as anti-Jo1, they define the full-blown antisynthetase syndrome. This includes ILD, arthritis, Raynaud phenomenon, and the classic mechanics hands. Again, knowing the antibody defines the entire systemic syndrome, which is much, much broader than just muscle weakness.
Now that we understand the clinical picture and these molecular war zones, let's talk about how we actually prove the diagnosis. It starts in the lab, but the lab results can be, well, deceptive.
They absolutely can. Creatine kinase, or CK, is the most sensitive muscle enzyme. It's elevated in almost all PM and DM patients with active muscle disease, often tenfold or more above the normal limit. But, and this is the crucial nuance we flagged earlier, the lack of CK elevation, especially in DM or CADM, should not delay the diagnosis.
You can have severe dermatomyositis with systemic involvement and a completely normal CK.
You absolutely can. The reason why is, well, it's possibly because the damage is focused on the capillaries and the edges of the fascicles, which doesn't always release massive amounts of CK into the bloodstream, or it's just because the disease is cutaneous only at that point.
That is such a critical clinical point. Normal CK does not mean you can stop looking for disease. What if CK is normal? Are there secondary enzyme tests we can use?
Yes, there's aldolase. Aldolase is another enzyme that's released from damaged muscle. Now, it's less specific than CK, but it is occasionally elevated when CK levels are normal.
And what might that suggest?
An elevated aldolase can sometimes suggest prominent perimyxal involvement or sometimes significant inflammation of the surrounding fasciitis, which is often seen in DM.
And the heart enzymes, CKMB, they pose a unique challenge because the heart muscle itself is at risk.
Right. Patients with myositis often have an elevated serum CKMB fraction even when their heart is totally fine.
And that's because
it's usually attributed to the CKMB being expressed in regenerating skeletal muscle, which is active during the repair process. But because we know these patients have an increased risk of a heart attack, you have to be able to definitively distinguish skeletal muscle enzyme elevation from true cardiac injury.
So how do you do that?
For that distinction, you need to measure cardiac troponin egony. That's a protein that is highly specific for myocardial injury. If that's normal, the CKMB is likely coming from the skeletal muscle.
Moving beyond the blood work, we rely on non-invasive imaging to guide us toward the source of the problem.
Yeah.
How does MRI fit into the diagnostic pathway?
MRI is invaluable. It's sensitive and non-invasive. We typically order a bilateral thigh MRI with S-star sequences.
Zestar sequences.
Short tau inversion recovery. It's a sequence that's highly effective at highlighting areas of increased water content. The edema that's associated with muscle inflammation just lights up brilliantly on the SDR sequences.
So it can show you the inflammation.
It helps to document active disease, even in patients with normal CK levels. And crucially, the MRI is also the roadmap for the muscle biopsy. It allows us to identify the most actively inflamed, non-atrophied sites to target, which helps avoid sampling error.
And can the MRI reveal subtle clues about the underlying subtype?
The patterns can hint at the diagnosis, yes. For example, IBM often shows a very specific pattern of involvement, with fatty replacement in the deep finger flexors and specific leg muscles.
In IMNM.
IMNM patients, especially those with the anti-SRP antibodies, tend to show earlier and more severe atrophy and fatty replacement than DM or PM, which really reflects the aggressive necrotizing nature of their disease.
Then we get to the electromyography, or EMG. What is its main purpose in this workup?
EMG is essential for separating the cause of weakness. Its primary role is to distinguish myopathic causes of weakness, meaning primary muscle fiber damage, from neuropathic causes.
So things like ALS or a pinched nerve.
Exactly. Motor neuron disease like ALS, nerve root compression, or a peripheral neuropathy. Myopathic changes on an EMG are very characteristic. You see increased insertional and spontaneous activity and low amplitude, short duration motor unit potentials. It basically rules out the nerve as the primary problem.
You mentioned an important technical consideration about the timing and placement of the EMG and biopsy. Can you reiterate that for us?
Yes, 2 rules of thumb here. First, we perform the EMG on one side of the body, and then we obtain the muscle biopsy on the contralateral side.
The opposite side.
The opposite side. You don't want the inflammatory response and the physical trauma caused by the EMG needle stick to interfere with or contaminate your biopsy result.
And the second rule.
If you are drawing blood for muscle enzyme testing, it should ideally be drawn before you perform the EMG, because the minor trauma of the needle can artificially elevate CK levels for about 24 to 36 hours.
Now for the biggest challenge in the differential diagnosis, the myopathy mimics. If a patient comes in with proximal weakness, what are the most critical diagnoses that must be excluded, particularly inclusion body myositis?
IBM is the quintessential myopathy mimic. The sources stress this repeatedly. When a patient is labeled with refractory PM, meaning PM that doesn't respond to steroids, the correct diagnosis is often IBM that was missed initially.
Which is why the muscle biopsy isn't optional.
It's required to definitively rule out IBM.
Let's detail the features that rule out PM and strongly favor IBM.
We need to look at 3 areas: the onset, the distribution, and the lab findings.
Okay, first, onset.
1. Onset and course. IBM has an insidious onset, progressing slowly over many, many years. PM is acute or subacute, progressing over weeks or months.
Distribution.
2. Weakness distribution. This is the strongest clinical differentiator. IBM is typically asymmetric and involves distal muscles. Specifically, the forearm flexors and the quadriceps are classic early targets.
The difficulty with grip.
Difficulty with grip, buttoning a shirt. PM is classically symmetric and overwhelmingly proximal. If you see a patient with difficulty buttoning their shirt and difficulty climbing stairs, you have to think IBM first.
And lab work.
3. Lab work. Serum CK levels are generally much lower in IBM, often less than 10 times the upper limit of normal, and sometimes only mildly elevated. PM, on the other hand, often shows massive elevations.
So, if a patient diagnosed with PM is refractory to initial treatment, the clinician should immediately re-examine the diagnosis for IBM.
Absolutely. The expected response to therapy is almost a diagnostic criterion itself. And I should add, while the classic rim vacuoles are sometimes absent in IBM biopsies, molecular markers like P62 positive inclusions can help. And the anti-CN1A autoantibody, while not always present, is highly suggestive of IBM.
We also have to be vigilant about distinguishing the DM rash from other dermatologic conditions, particularly cutaneous lupus erythematosus or CLEO.
This is a tricky area because histologically, on a biopsy, DM rash lesions are often difficult to distinguish from CLE. They both show something called interface dermatitis.
So you have to rely on the clinical features.
Almost entirely. The key differentiators are the ones we discussed earlier. The intensity of the pruritus, the itch, strongly favors DM. The involvement of the nasolabial folds by the facial erythema favors DM. And of course, the presence of DM-specific signs like the Gottron papules and the Holster sign.
Yeah, sure.
And another clinical pearl is that DM patients have a much higher frequency of adverse, sometimes severe, reactions to anti-malarial therapy, which is a standard treatment for lupus.
Finally, we must always take a meticulous drug history to rule out drug-induced DM.
It's a crucial differential diagnosis because stopping the offending drug is the cure. Medications like hydroxyurea are the most commonly reported causes of DM-like eruptions.
And others?
Other agents, including immune checkpoint inhibitors, which is a critical group given the rise of immunotherapy statins, and anti-TNF therapies, can also induce myopathies that perfectly mimic DM or PM. It requires a very careful drug exposure history to avoid misdiagnosis and unnecessary long-term immunosuppression.
When the diagnosis of DM or PM is confirmed, and we've ruled out all the mimics, what is the initial foundational step in therapy?
The cornerstone remains the same: glucocorticoids, steroids. They are proven to improve strength and preserve muscle function. However, the core principle now is combination therapy right from the start. We are moving away from steroid monotherapy.
Why the necessity for combination therapy immediately? Why not just try steroids alone first?
Because of the high relapse rates and the inherent failure rate of steroids alone. The sources suggest that simultaneous treatment with high-dose systemic glucocorticoids and a conventional synthetic disease-modifying antirheumatic drug, a CSDMARD, is required.
And what's the evidence for that?
Starting a CSDMARD right away, something like methotrexate, azathioprine, or mycophenolate mofetil, is essential because up to 50% of PM patients do not respond adequately to glucocorticoid monotherapy, and those who do have a higher risk of relapse if the steroid is used alone.
So for a patient with, say, moderate muscle disease, what is the structure of that initial regimen?
For a patient with significant but not life-threatening weakness, we'd initiate high doses of glucocorticoids, typically prednisone at 1 milligram per kilogram daily, up to a max of 80 milligrams, and combine it immediately with the CSDMARD.
And how do you choose the CSDMARD?
The choice is based on clinical characteristics. For example, if the patient has underlying ILD, you might favor mycophenolate or azathioprine, and you'd want to avoid methotrexate due to its potential for lung toxicity.
But what if the disease is severe? What if the patient is struggling to breathe or swallow, or has that rapidly progressive ILD that requires immediate high-stakes intervention?
That requires immediate aggressive induction therapy. For patients with critical involvement, severe dysphagia leading to aspiration risk, diaphragmatic weakness, or weakness preventing essential self-care, the standard aggressive induction is a high-dose pulse of intravenous methylprednisolone,
IV steroids.
1 gram daily for 3 consecutive days. This is immediately followed by IVIG, or intravenous immunoglobulin.
How does IVG work?
It's dosed at 2 grams per kilogram divided over 2 to 5 days and is usually administered monthly. It acts quickly as an immunomodulator and is especially useful in these severe acute disease presentations.
And for advanced cases, or those who fail to respond to the initial regimen?
We have advanced immunosuppressive agents. Biologics like rituximab and also cyclophosphamide are alternatives. Cyclophosphamide is often reserved for severe refractory interstitial lung disease, particularly in those with antisynthetase syndrome.
And rituximab.
Rituximab, which is a CD20 B-cell depleting agent, has proven effective, and some data suggest the fastest clinical response is often seen among patients with antisynthetase or anti-My2 autoantibodies.
Once treatment is started, how do we monitor the patient's progress? How do we know the treatment is actually winning the war against the immune system?
Monitoring is a multimodal process. It involves lab work and functional assessment. We suggest checking muscle enzymes, primarily the CK, every 2 to 4 weeks until they show a consistent downward trend and ideally normalize.
But there's a clinical caveat there, right?
There is. It's a very important one. Strength recovery lags significantly behind enzyme decline. You might see the CK drop dramatically, but the patient may not feel stronger for several months.
So we need patience. How do we objectively track strength improvement?
Muscle strength should be objectively checked approximately every 3 months. You can use standardized manual muscle testing of key proximal groups, like the deltoids and hip flexors, or functional tests, like timing the patient rising from a chair with their arms crossed.
And there's a debate about what the goal is.
Right. In clinical practice, there's a constant debate. Is it necessary to increase immunosuppression solely to normalize the enzymes if the patient's strength has returned? Most experts prefer to aim for enzyme normalization if possible, but functional recovery is always the paramount goal.
Once the patient is clinically and biochemically responding, when do we start tapering the steroids? And how do we manage the terrible irony of glucocorticoid myopathy?
Glucocorticoid tapering must be slow and cautious. The terrible irony is that prolonged, high-dose steroid use can cause its own muscle weakness, glucocorticoid myopathy, which perfectly mimics the disease we are trying to treat.
So how do you avoid that?
We start a very gradual taper only after about 4 to 6 weeks of the initial high-dose therapy to reduce the risk of this drug-induced weakness.
That must be incredibly confusing for the patient and the physician. Is the disease relapsing or is the treatment causing the problem?
It is intensely confusing, which is why the taper must be so slow. A safe taper takes a long time, usually 9 to 12 months, to safely reach a low-maintenance dose or to discontinue it completely.
Can you give an example of a taper?
Sure. A typical regimen might involve a rapid drops, say 10 milligrams weekly, initially until you reach 40 milligrams daily. And then you switch to much smaller, slower steps like 2.5 milligram or 1 milligram weekly reductions as you approach the physiologic doses. The gradual approach is key to avoid both disease relapse and medication side effects.
And when do we try to stop the other immunosuppressive agents, the CSDRNs?
The glucocorticoid sparing agent is generally continued until the patient has achieved a glucocorticoid-free remission for at least 1 to 2 years. Tapering the DMARD is a highly individualized decision based on the risk of relapse and patient preference.
Are there exceptions?
The major exception is patients with immune-mediated necrotizing myopathy, IMNM, particularly those who are anti-SRP positive. They often require long-term, sometimes lifelong, immunosuppression to maintain remission due to their very aggressive phenotype.
Finally, we need to address essential co-management and prognosis. Besides medication, what non-drug therapies are mandatory?
Physical therapy must be introduced early. For patients with severe weakness, passive range of motion exercises are needed immediately to prevent painful joint contractures.
And then?
As soon as the patient shows objective signs of strength improvement and can tolerate it, they must transition to active exercises and carefully controlled resistive training to rebuild the lost muscle mass and strength.
And given the risk of aspiration we discussed, what co-management is necessary for dysphagia?
For patients with documented dysphagia, management focuses relentlessly on preventing aspiration pneumonia. This involves consultation with speech therapy, counseling on consuming semi-thick diets, elevating the head of the bed during sleep and after meals,
And sometimes more extreme measures.
and potentially needing a temporary or even a permanent feeding tube in severe cases to ensure adequate nutrition and protect the airway.
Before concluding, let's return to the mandatory post-diagnostic screenings. This is one of the most actionable takeaways from the source material.
Every single adult patient diagnosed with DM or PM must undergo mandatory screening for 2 critical, life-altering complications: interstitial lung disease and malignancy. This is non-negotiable, even if the patient feels perfectly well.
What does that ILD screening entail?
Chest radiographs and pulmonary function tests, or PFTs, with specific measurement of the diffusing capacity of carbon monoxide are essential for all patients, regardless of respiratory symptoms.
And if there's an abnormality?
If abnormalities are found, or if the patient is high risk, meaning they harbor those antisynthetase or anti-MDA5 autoantibodies, a high-resolution FES-CT, an HRCT scan, is required to map out the extent and pattern of the lung disease.
And the cancer screening?
The risk of malignancy is significantly increased, particularly in DM, and especially in those with the anti-TIF1 gamma or anti-NXP2 autoantibodies. Most experts recommend a comprehensive malignancy screening that goes beyond the standard age-appropriate screening guidelines.
So you have to look harder.
You have to look harder. This involves a meticulous history, physical exam, and specific imaging and lab work tailored by age, sex, and risk factors. And finding and treating an underlying malignancy is crucial because the myositis symptoms often remit once the cancer is treated. And of course, the presence of malignancy heavily influences the overall prognosis.
So summarizing the outcome, what factors lead to the worst prognosis?
The sources consistently summarize several key risk factors for a poor outcome: increased age at diagnosis, male sex, greater muscle weakness at presentation, involvement of the pulmonary system with ILD, severe dysphagia, an underlying malignancy, and, most importantly, a delay in diagnosis or initiation of treatment.
So speed is of the essence.
Early, aggressive, and correct diagnosis based on mechanism, not just on symptoms, is paramount in survival and functional preservation.
We performed a deep dive into dermatomyositis and polymyositis, and what we found was a complex landscape of distinct, molecularly defined diseases. We moved from the simple complaint of sore muscles to understanding the nuances of the microscopic war zones.
That's right. Dermatomyositis is now so strongly defined by that type 1 interferon alarm signal, the IFNB, that drives the dense expression of MXA protein and a vasculopathic attack on the muscle fiber edges.
And polymyositis, meanwhile.
It's now largely recognized as a basket of these distinct diseases, whether it's the specific T-cell invasion pattern or the complement-driven necrosis of IMNM. It's not one thing anymore.
The journey through the clinical manifestations was equally revealing, moving from the functional difficulty of lifting a gallon of milk to the visual artistry of the Gottron papules, the heliotrope eruption, and that mysterious holster sign.
It's incredible how specific they are.
And what determines the severity or even the urgency of the disease often comes down to a single, tiny molecular marker found in the blood.
That is the astonishing power of precision medicine. We learned that specific autoantibodies, like anti-MDA5, flag a patient as being at extreme risk for a rapidly fatal lung condition, even if they show no signs of muscle weakness.
That's amazing.
This ability of a single microscopic marker to predict a macro-level life-and-death health event is a powerful reminder of how far immunology has come.
Which raises an important question for you, the listener, to mull over. If dermatomyositis and polymyositis diseases that were once lumped together are now split into distinct conditions based on these highly specific autoantibodies, what other common illnesses today might actually be multiple genetically or molecularly distinct diseases?
Right.
Diseases like certain forms of hypertension or even major depressive disorder that only require the right molecular key, like a rare autoantibody or specific genetic signature, to unlock a precise prognosis and perhaps a targeted cure.
The move from broad symptom-based categories to precision mechanism-based phenotypes is redefining how we understand immunity and disease across all medical disciplines. It's happening everywhere.
That's all the time we have for this deep dive. Thank you for listening.